Hello, everyone, and welcome to Medical Insights. My name is Dr. Andy, and today we are going to be talking about hydrocephalus, which is a brain condition. And to help us understand the topic is Dr. Boipelo, who is a young and inspiring neurosurgeon. Dr. Boipelo, welcome to Medical Insights.
Thank you so much, Dr. Andy. Thank you.
Thank you for coming. And before we get into the topic, I want to know, you are a neurosurgeon.
Yes.
A young one, right?
Yes.
What inspired you to go for this specialty?
I've always known that I want to be a surgeon.
Awesome.
Because I love the adrenaline that comes with the job and the fact that you have to make critical decisions that are very vital and pivotal in determining whether a patient lives or not. That's the kind of adrenaline that I like.
Yeah.
So going into medical school, it started with high school. Actually, I enjoyed biology more and the brain studies more. And then when I came to varsity, I enjoyed the neurosurgery, the neurology part rather more.
Yeah.
And as we were dissecting in second year, I enjoyed, dissecting the brain because it's quite a mystery how everything that we do is just controlled by the brain. The fact that I'm sitting here talking to you, the fact that you are able to hear what I'm saying
and
process what I'm saying, understand what I'm saying, and respond accordingly is because of the brain. Now, to be able to operate that and mend things from the brain and the spine is just amazing. So I thought, this is what I want to do, and I'm going to do it. And I did it.
And I understand, just like the heart is in the chest, you get the pericardium, the pericardial fluid protecting the heart.
Yes.
How is this organ that you work with on a daily basis protected?
So it is, if I may break it down, if we talk about maybe mechanical forces from outside, maybe trauma, the brain is housed in a vault called the skull. The skull is a very thick, rigid bone which will protect it from external trauma. And as you go inside, it is covered by different layers. They call it the meninges. There's 3 types. There's the dura, arachnoid, and pia mater that actually cover the brain.
I remember the dura. It's like a sack,
it's very thick. You have to actually cut it out when you're operating the brain. You open the dura for you to get to the.
Do you guys suture it back? How do you suture it?
It depends, actually. So if in a setting of trauma and that part of the dura, maybe it's damaged, there's actually what you call pericardium, one of the layers of the scalp. If you remember, the scalp is divided into 5 layers. There's also the pericranium. You take that pericranium and you augment the dura. You suture the dura and then you sort of patch the dura with that part of pericranium to accommodate that amount of dura that was damaged that you can primarily repair. But there are other synthetic means of repairing a dura, like other products from different companies, but primarily we prefer autologous graft, something that is from your body, which is the pericranium, which you can use to actually suture back the dura. So yes, suturing the dura is an integral part of neurosurgery. We actually
I hope somebody who's watching wants to be a neurosurgeon one day, and they're quite big.
So we want a watertight dural closure because we don't want CSF to leak out, because CSF is in the subarachnoid space in the brain. So talking about protecting the brain, cerebrospinal fluid is also a fluid. It's clear, like fluid, that has many functions in the brain. It cushions the brain, supports it from shock, external rotational acceleration forces. It also has metabolic functions for the brain. It also forms as part of homeostasis, meaning maintaining a balance in the brain. Hormones are secreted, chemicals are secreted, electrolytes are secreted. So the CSF just makes sure that everything is in balance and also takes out waste from the brain to outside.
Because the brain is constantly functioning.
It has to. It is even when you're sleeping. When you're sleeping, the brain is actually functioning.
Quite interesting. And now to the topic of the day, we are talking about hydrocephalus. Can you explain to our viewers at home what hydrocephalus is?
So hydrocephalus is an excess accumulation of this fluid, cerebrospinal fluid, in the ventricles. The ventricles are actually little pockets that are inside the brain that house the cerebrospinal fluid. So if there's too much of the cerebrospinal fluid, an excess amount of cerebrospinal fluid in the brain, then we deem it to be hydrocephalus. So it can affect the young, newborns, the young children, even adults. So depending on your age, it has different causes. Let me start with the young, congenital causes of hydrocephalus. So you find that some babies are actually born with hydrocephalus. So when they are born with hydrocephalus, it could either be because of either there is a congenital condition that predisposes the child to that. For an example, what you call Chiari-2.
When you say congenital,
meaning you are born with it. You're born. You didn't acquire it. You are born with it. So the most commonest type of congenital hydrocephalus that we see is because of a condition called Chiari-2 malformation. So Chiari-2 malformation is a congenital abnormality which also involves what we call spina bifida. Spina bifida is when there's abnormality with the spine of the child. It can be in either level of the spine, the cervical, thoracic, or the lumbar or lumbosacral, where the skin covering the back is open. So it can either be open or closed. So when it's open, you just know that this child, I need to watch out for hydrocephalus. I need to watch out for what we call Chiari malformation, which is a syndrome. So how...
Meaning it occurs with other things that you need
there's that abnormality at the back, and there's also hydrocephalus. So how one can prevent that from happening, like I said, it can be congenital, it can be familial. For an example, if you've had a child, if let's say a female has had a child who had spina bifida, they have 2% chances of having another child if the second child with that malformation. And if 2 children are born with it, they have like a 6% chance of having that third child be born with this Chiari-2.
So there's a role of genetics.
So there's a role of genetics. So what I would encourage is that the earliest time one finds out that they are pregnant, they need to go early to the clinic to book. To book, because when you book, they do a series of investigations. They take bloods. The investigations that they do in the first trimester, which they will take bloods, and then the second trimester, what they will do also, they will also do an ultrasound to just
I wanted
check.
to find out, as you were saying, that hydrocephalus can be congenital. Is to ask if it can be picked up, because usually part of the biometric measurements that we do at ANC is to measure the head circumference. Could one anticipate as far as in utero? That's what I'm saying. In utero, how you can pick it up, your first trimester, you'll take a series of bloods. So if one is at highest risk, like family history of having that Chiari malformation, can now tell the doctor that this is what is happening. They have a child. When you say Chiari malformation,
Chiari-2.
Is there a way of simplifying it so that maybe our viewers can just understand? Because I see that you keep on mentioning.
Let's just say spina bifida. Let's just say spina bifida is that with abnormality. Where there's failure of closure of the skin. Sometimes it's not so obvious where you can see that there's an abnormality, the skin is not closed. You can see maybe there's like a dimple at the lower lumbosacral area, or there's like a tuft of hair around there. You understand? That is what we call the occult version. It's concealed. But the one that is open is called the aperta, the one that you can just see. So the reason why we advocate antenatal visits and we also advocate for optimal nutrition Preconception, you need to make sure that you optimize your consumption of folic acid, because the lack of folic acid is associated with the failure of closure of the spinal cord. This happens very early in pregnancy, day 25, day 28.
Yeah.
So that time is not even a month yet that you know that you are pregnant. So if you are planning to have a child or you are preparing for that, it is very important to optimize your nutrition, right? Where you take folic acid, you make sure that you are taking a well-balanced diet, and you consult your obstetric and gynecologist to tell them that you are planning to, you know, to have child, so that you can optimize your nutrition. You can be motivated to go in early and book, so that these things can be detected early. So in the second trimester, where you do an ultrasound, right? You are able to detect dilated ventricles already at that stage. So once you see
Can there be any intervention at that stage?
So at that stage, you cannot intervene in the second trimester. It's just counseling that you can give to the couple to say that I've picked up 1, 2, 3, 4. And these are that your child might be born with hydrocephalus, and this is how the life will look like. This is what will happen. So it is up to them whether they will continue with the pregnancy. So it's very important so that parents are also prepared to say that these are the things that they might face. Yes.
Is it a common condition? Is it a common condition?
What I can say to you is about 10 in 1,000 births. These are not South African stats. I think these are United States stats. So children may be born with hydrocephalus. So I wouldn't say it's common, but in a center where I work, because it's a specialized center, we see that a lot. Yes. So if it's something that we can prevent by empowering women, a young couple that wants to prepare to have a family, to optimize the nutrition and intake of folic acid, you know, maybe 3 months before conception, that would be something that would really, really go a long way. So that spina bifida cherry tumor formation is part of the causes of hydrocephalus. There are other causes of congenital hydrocephalus, where you have what we call aqueductal stenosis. Aqueductal stenosis, it's where, let's say, one of the, should I say, channels of flow of cerebrospinal fluid is blocked. So if it's blocked, there will be no way where this fluid will circulate properly. So if it's aqueductal stenosis congenital, it may cause hydrocephalus. If there's a tumor in what we call the choroid plexus, the choroid plexus is exactly where CSF, 80% of the CSF is produced. So if there's a tumor that causes excess production of cerebrospinal fluid,
so
it will lead to
tumors can also still be part of congenital causes.
Yes.
So babies can be born with tumors.
With the choreas.
Yeah, because normally when somebody talks about tumors, cancers, neoplasms, you often think of the elderly, you know. I know even the ophthalmologist, we had the ophthalmologist the other day was telling us about some eye tumors in the eye on children. I think it's quite sad. Honestly.
It is very sad. It is very sad.
So go ahead. You were still telling us some of the causes.
Those are some of the congenital causes. Your tumors, your choroid plexus tumors, aqueductal stenosis, cherry 2 malformation can be also cherry 1 variant. And part of the causes as well is in premature babies. They have what we call germinal matrix hemorrhage. So germinal matrix is a layer in the brain that is highly metabolically active for producing cells in the brain. So that layer is just above the ventricles. Remember, I said the ventricles is those pockets where CSF is produced and collected. So if you have, for an example, in prematurity, they're prone to premature births, birth asphyxias, which will lead to disruption of the germinal matrix leading to a bleed. So once those kids have intraventricular bleeds, especially in prematurity or in kids that have had birth trauma, birth asphyxia, neonatal distress syndromes, respiratory distress syndromes, they predispose that germinal matrix to hypoxia, hypovolemia, leading it to be unstable.
Like lack of oxygen?
Lack of oxygen, leading it to be unstable and bleed. And once they bleed, then they may develop hydrocephalus. So those are the causes for the young ones, the newborns. And moving to the elderly, trauma can also cause a bleed in the ventricles, leading to hydrocephalus.
So how does trauma, so if somebody suffers trauma and they bleed into the ventricles, is it, what's the mechanism? Is it the CSF is blocked?
It's disruption of the blood vessels within. So once there's a disruption of blood vessels, they will bleed into the ventricles. So what happens is that the clots will obstruct the pathway in which CSF will flow, which will lead to hydrocephalus.
CSF is that clear fluid around the brain that you spoke to us about.
So trauma infections like meningitis can be bacterial meningitis, viral meningitis, TB meningitis commonly. They are also, I've seen them present with hydrocephalus as adults. Patients with strokes that tend to bleed into those small pockets, the ventricles. They also
it sounds like the ventricles are quite a sensitive area. It's like any movement you cause me, I'm going to retaliate.
So that is where 80% of this fluid is produced within those pockets called the ventricle. So anything that disrupts CSF in that ventricle has a potential cause of obstruction of the flow of CSF. Other causes like adult tumors, which block the pathway of flow of CSF, can cause hydrocephalus.
Awesome. Amo, you've already mentioned some of the symptoms that the adults can present with, but I want to know about the children. Either congenital hydrocephalus or children that therefore develop the condition. How do they present? What are the symptoms they often?
So the symptoms, it depends if you remember when children are born, the sutures are not yet fused. Those bones are not yet fused like mine and yours. They will get to a stage where they will fuse. So if they haven't fused, they allow expansion if the head increases in size. So what the moms need to know is the normal head circumference of the child. And if they see that that head is getting bigger in size, they need to go to the nearest doctor or to consult.
So a sign to look for is a head
that is increasing in size. If you have a measuring tape, you can just take your head circumference. Just if a measurement increases by 1.5 in a week, that is abnormal. And if you plot
because generally you expect them to grow, but then if it's beyond what is expected, as you're saying, more than 1.5,
in
then
a week,
it may be pathological.
So those road to health charts, they have growth charts, length, height.
And oftentimes they go for their days follow-ups,
Head circumference, if you plotted your head circumference and it's above the 90th centile, that shows that the head is growing at an abnormal rate. So if the head is growing, if the child becomes irritable, the child doesn't want to eat, the child is always vomiting, the child is crying, the child is not responding as they used to. Sometimes if it gets too advanced, you will start to see the veins in the scalp. They will distend, and then you will see their eyes. They have what you call a sun-setting eyes, meaning they've got an upward gaze palsy. So you'll just see the eyes like looking down and not be able to look up. And the head will also be bigger. And if it was a child that was normally just developing normally, you will see that there will not be a normal progression of milestones in that child, in addition to the increase in the head circumference. So what we look out for, the signs of raised intracranial pressure, it's
This
headache.
is now a doctor's
Yes,
level. Yeah.
yes. So if you see a child is vomiting constantly,
Yeah.
vomiting, and they are lethargic, they're not playful as
Yeah.
usual, the head is bigger, and it looks bigger, and what you look at is the craniofacial disproportion. The face will look smaller, but the head will be big. You understand?
Yeah.
Because if you can look at a normal person now, the proportion of the face and the head, it's normally aligned.
Yeah.
So if the face looks smaller but the head is big, it's called what you call a craniofacial disproportion. So these are the things that you can look out for in young children.
The whole aim of being a doctor is to diagnose and treat. So, and possibly prevent, But let's talking about hydrocephalus. How is it treated? Is it a specialized condition? Can GPs treat it, or who's supposed to treat the condition?
Neurosurgeons treat hydrocephalus. There is if we treat you medically, meaning we don't operate, we prefer you are under our observation and care, because we are worried about your clinical progression, whether you're going to deteriorate or respond to the treatment. And if you don't respond, we need to act very fast. So medical treatment is not, we don't practice it a lot, because the most commonest times we see hydrocephalus is when it's at its acute, meaning it is life-threatening stages.
I should imagine that it's life-threatening.
Yes, because imagine there's just accumulation of this
and I've seen
fluid
babies with
in your head, and there's just nothing. The head is just, the pressure in the brain is too high. And if the pressure is too much, remember when we spoke about the medulla, where there is a respiratory center and the cardiovascular center. So once the pressure is too high, the medulla will sort of what we call herniate. The tonsils will herniate, compressing the medulla and all that, and there will be arresting of respiratory and cardiovascular function, of which we don't want. So we want to treat it as an emergency basis, depending on what the cause is. And we have what we call external ventricular drain. Is if we put an external ventricular drain through the brain in the ventricle to allow this fluid to drain outside in a collecting bag temporarily. So
is this done in theater? Is this procedure done in theater?
We do it in theater, and then we admit you to our neurointensive care, high care, to observe your progression. And
at this stage, if you're going to put an external shunt, let's take a baby for example, will they still be able to carry out their normal functions, see, play, eat, or what's the brain function at that stage?
It depends at what stage you present it. If you're a newborn, you may be able to do functions of a newborn, but you'll be limited in terms of mobility, because you have now this drain that is connected to this chamber that is now next to you on the bedside. So when you move, there are actually bedside protocols that we tell the mothers to say, okay, if you want to breastfeed the child, you need to just close position because if the drain is lower than the baby, the fluid will drain more than the expected or more than the normal limit, causing complications. So we don't want it to overdrain. We give them bedside procedures or manners in which to care for these babies. If they're breastfeeding, they will handle it in a way, close it, and then be able to breastfeed. And then once the child is fine, they can just put the child on the bed, and then they will open it to allow the CSF to drain, normalizing the intracranial pressure. If it's a child that is young, maybe a toddler that is active, normally they understand that, listen, you've got this thing here. You don't need to be moving a lot, but normally.
So there isn't cognitive impairment in general with hydrocephalus. Do you anticipate cognitive impairment?
It depends what is the cause of the hydrocephalus, like I said.
And maybe which area of the
There's different ways to explain it. For an example, if, like I said, if you present in a congenital type of hydrocephalus, which is part of a syndrome, so there will be limitations of functioning that one can do. For example, going back to the Chiari spina bifida, those children may be slower in terms of developing than other kids because of that syndrome as a whole. And they're also associated with multiple other problems, cardiac problems, long bone problems, abdominal problems, and they have issues with bladder control as well. So that is the type of counseling that we also tell the moms to say that in the long run, this is what's going to happen. So it's a multidisciplinary type of management, not only neurosurgeons.
The whole team has to be on board.
Orthopedics, if they have club feet, urologists, anticipating the
occupational
speech,
everyone
comes. So that is an EVD, an external ventricular drainage. We just put it temporarily, either because there's too much blood in the ventricles, or there's an infection that you just want to clear out, maybe because of meningitis. You can't shunt
an infection. So it makes sense.
And then once you have observed you and make sure that you are clear of the infection or whatever pathology, whatever problem, and you still need a shunt, we then take you back to theater to now put up what we call a ventricular peritoneal shunt. You just put up a catheter that goes in the brain, and then it tracks underneath the skin, and then it drains the fluid in the peritoneum. So we found that peritoneum is in the abdomen. So we found that
used to what runs the jargon just comes off like that.
So because there's excess amount of fluid that is being produced, right? It needs to drain somewhere. And like you said, we can't keep on draining them externally, impairing the function and mobility and all that. So if it drains in a space which is in the abdomen, the peritoneum, the peritoneum has been seen to be a good site for draining and absorbing that type of fluid. So we just place a shunt in the brain, in the ventricles, then we tunnel it under the skin, and then it comes and drains in the abdomen. There are other types of shunting where you can put it in the pleural space. You can put it in the ureter. You can put it pleural in the lungs. Yes, there's a space between the lungs and the ribs called the pleural space. You can put it there to drain. But that's a more complicated thing. So there's risks of doing that because now you are affecting the lungs. Yes. So in rare cases where the patient is not tolerating a shunt in the abdomen, like we've had multiple cases where children are allergic to these.
I wanted to ask.
You understand? The material that the shunt has, the kids can be allergic to it. So you will see that the shunt is constantly not working, blocking and all that. So we then resort to say, okay, what else can we do? Can we put up a ventricular atrial shunt, which is into the heart, which is more complicated.
Do you operate with the cardiothoracic surgeon?
They would have to be there. They would have to be there. So it's quite rare that we get to put these other shunts. Your ventricular atrial, ventricular pleural, ventricular urethral is when now you will also need the urologist to be there. But the commonest is the ventricular peritoneal. We do it. We do it. And other forms of diverting or treating hydrocephalus, we can do an endoscopic procedure. We call it an endoscopic third ventriculostomy. So we go through the brain, go through the ventricles, and look for the third ventricle. So there are many ventricles. There's lateral, third, and fourth ventricle. So we go to the third ventricle. Remember, ventricles are those pockets that contain CSF. Third ventricle, the floor of the third ventricle, we just open it. And then we fenestrate it and just let the fluid, sort of like an egress pathway, not through the normal channels, but just to allow CSF to also drain.
To flow.
Interesting.
So now I want you to just, what are the basic home care? Like, let's say a mother has had a child who has had a shunt, for example. What are they supposed to look at home or teach the child? What are the home care?
So what we normally educate the mothers is about to look out for the risks of the shunt blocking. Because the most commonest complication of inserting a shunt is blockage. And if it blocks, they will present again with those signs of raised intracranial pressure to say, if the child has been walking and now they're no longer walking, they're having weakness of the body, they're not eating, they're vomiting, they are just lethargic, all those symptoms. Look at the eyes, look at the head, look at the scalp if it's still a young child where their sutures will also sort of like splay.
Yeah.
The fontanelle will be bulging and tense. It's not supposed to be like
So
that.
when they see those things, it's a
When they
call
see
of
those things,
go back to your doctor.
go back to the doctor. We need to check out the shunt if it's working, and also look out for the operation sites. The wound can also develop infection. The wound on the head and on the abdomen, just look out for signs of maybe the wound becoming too red, fluid coming out of the wound, the stitches becoming too loose, the wound opening up. But those that were well shunted and they're doing fine, they can actually progress.
Does this now become a chronic condition? Is there a point maybe in their teenage years where the shunt is completely taken off?
From what I've noted is that there are those, from what I've seen in our setting, those patients that have had shunting done at a very young age, they come for follow-up, and they're doing well.
Okay.
There's few of those ones where maybe the shunt is blocked, the shunt is not functioning, we need to change the shunt. And those that we don't change shunts on, they just continue life normally. So
but
there's a selected
continue?
few. Yeah, they will continue having a shunt.
Even as an adult?
Even as an adult, yes. Okay. Unless it gives you problems. If it gives you problems, then we will need to remove it and put up a new shunt. Okay. If it does not, you just continue life as normal.
Okay.
Yeah.
All right. Wow, quite mindful. This is actually quite a huge topic.
And I don't think we have not covered all of it. No.
I know, right? There's still a lot. I myself am feeling, oh my goodness, I feel like people at home have there's so many questions as well, but I'm hoping that we can have you again, either to expatiate on the topic or for you to talk to us about another neurosurgical condition. Dr. Boipelo, thank you so much for gracing us here at Medical Insights. I know that your schedule is absolutely busy, but thank you for taking time to come and educate us here in studio and our viewers at home. Do you have any last words for our viewers at home? In terms of how to take care of your brain from the neurosurgeon.
How to take care of the brain from the neurosurgical
sleep.
What I can say is just maintain a balanced lifestyle. Go to gym, exercise, eat healthy. And go to church, get born again, pray. Yeah,
absolutely. Get born again, pray, and remember that the Healing Streams Live Services with our Men of God is upcoming. I'm sure the details are displayed on your screen right now. Make sure that you register yourself and register somebody that you know who may be living with a medical condition and could do with a miracle from God. From us here at Medical Insight, that's all we have time for on today's episode. Until our next episode, stay healthy and stay blessed. See you then.